sure that we have a proper demo before I expect you guys to do that when the time comes for it. Okay, everyone should have access to record. If you do not, just please let me know. Okay, let's get right back to it, everybody. Let me get the PowerPoint pulled up. Which I do not have pulled up, so I am sorry. Give me a second here. There we go. All right, guys, so we finished up last week talking about the sterile gloves. I'm not going to talk much more about that today because from this point, it all comes down to me giving you guys a proper in-person demo of how that works and then us doing the practicum on it. Like I just said, that is slightly delayed. We'll get to that when the time comes, once we get the go-ahead. And hopefully, we'll be able to just do it all together as a class if they keep changing these restrictions like they're currently doing. Maybe by the time we get to do it, we'll be able to have a full class demo and not have to break into such small groups. But we'll see whenever we get there. The next thing we're going to talk about today is what we call dressing changes. So when it comes to dressings, this is another area within the hospital where we definitely got to practice that aseptic technique. And some of you may have already seen this. By the way, can you guys hear me okay? Audio's good? Okay. This may be something you guys have seen in the hospital already is people with multiple types of dressings on wounds and infected areas of their skin. And obviously, when we're dealing with an infection and or a wound, especially in that hospital setting where contagions are so prevalent and prominent, we've got to practice the aseptic technique when it comes to changing out those dressings. And yes, there may be a point where you have to change some of these dressings yourself. You might walk into a room and see a patient where their dressing's hanging off and just hanging by a little tiny piece of tape. And it's your job as a technologist not to say, oh, well, that's what the nurse will take care of. No, that's where you will step up and the supplies are there and you may be in a situation where you have to change that dressing yourself. Now that's something we're going to practice that sterile aseptic technique because like we said, we don't want to just put some random gloves on or especially not use our bare hands when we're changing out those dressings for these patients. And also, you're going to be protecting yourself because you don't know what that patient has. You may not have read the report. They may have a wound that's leaking all over the place. And the last thing you want is that wound to leak all over you on your clothes. You're going to infect yourself and infect all those around you. So that's definitely another area where we're going to practice that proper sterile aseptic technique when it comes to doing those dressing changes. And you're going to see all kinds of different dressings out there in the hospital. There's various types. But I would almost say, even if it's just a Band-Aid that you're changing, I mean, at the very least, have yourself some gloves on, even if it's not something you would call an aseptic technique kind of situation. I would treat all of them as such, personally, just because you don't know what these people have. You don't know what's contagious. And you're just going to do yourself a favor and those around you just properly practicing that hygiene and aseptic technique no matter what kind of dressing change you're doing. And you'll see it says here gowns are required. Definitely required because, as I was saying, some of these wounds get very nasty. They might be leaking fluids. And the last thing you want is that getting all over your clothes. You don't want to get it on your equipment. And I didn't put it here in the text, but something you're going to want to do, especially if you go into a room where someone has dressings, whether the dressing is something that you're actually in there changing or tending to, or if you just did a regular x-ray where you moved the patient, put the cassette behind their back, took that portable x-ray, you want to go ahead and wipe your machine down. Definitely wipe your machine down with a cavi wipe, sterilize it, because you just don't know what you may have touched or brushed up against accidentally. And it's just a better option overall to go ahead and wipe that stuff down just to protect yourself, because at some point you're going to take the gown and gloves off. You're going to be pushing that machine down the hallway and you don't know what kind of contagions may have gotten on that machine between that patient. So go ahead and wipe it down. Make sure you cover everything properly. Something else you won't see here and something I want you to commit to memory is most of the time when we do portable x-rays, we're going to use what's called a cassette cover. A cassette cover is simply a plastic sheet that we're going to stick the cassette into. It's going to protect that cassette from any kind of contagions or fluids that might get on that cassette, keep us from infecting everything, keep us from infecting ourselves, and keep those fluids from getting into that cassette and messing up some of the circuitry within it. Because these X-ray cassettes, because they're all digitized these days, they're extraordinarily sensitive. I mean, just the smallest amount of fluid can get in those cassettes and completely warp them and destroy them and mess them up. There's been a lot of techs who have messed up a lot of cassettes. And to give you some perspective, on a digital machine, a digital cassette typically costs at minimum $100,000. That's for one digital cassette on a portable machine, $100,000. Some will range all the way up to $500,000 depending on the size and the brand. So it's very, very expensive stuff. And last thing you want to do is put yourself in a situation where you're going to mess this equipment up and you're costing that department a lot of money. And that's going to not exactly come out of your paycheck, but it'll come out in another way in that you're not going to get the best ratings in your department when it comes time to evaluate you because you made those careless mistakes. So always be careful, cover things properly, wipe them down. And I got a little off subject here on the dressings, but anytime you're in those rooms with those dressings, practice that proper technique just to safeguard yourself and the equipment you're working with. In every dressing, every single dressing, keyword all, should be treated as though they're infected because we just don't know sometimes. Not everything's properly labeled. Not everything's properly written down. You got a lot of nurses that aren't doing their job properly. They're not always going to communicate accordingly. So if you see some kind of dressing, and I even go as far as say someone with even just a simple Band-Aid, treat them all as if it was a 100% infected area on that patient. Just to safeguard yourself, those around, and safeguard your equipment. This is an example right here, just some of the kinds of dressings you might see when you're out there, guys. Most common would be this one on the left here, little blue ones. Once again, you see blue, that should be a warning. You don't want to touch the blue. Same goes for dressings unless you have to actually assist in changing out that dressing. And yes, like I said, you may find a situation where you're doing that. Especially, for example, let's say they come in for an x-ray in your x-ray room. They have a dressing like you see right here, and it falls off while you're positioning them. Well, you're not just going to send them back with that wound exposed. You're going to have every x-ray room, every department is going to have this equipment on hand. So you've got to know how to replace that dressing properly while keeping that aseptic technique, not infecting and messing up your whole room with all kinds of infectious agents. So that is something you will learn to do. I mean, even gauze over here on the right side, gauze, that should be considered a dressing. You want to be careful. And even things like this on the bottom, a simple little brown Band-Aid should still, that's my opinion, by the way, on the Band-Aids. A simple Band-Aid should be treated as infectious because you can never be too careful when it comes to protecting yourself and others on these infections within the hospital, especially these days with everything going on. So now we're going to talk about a few different procedures some people have had done, where when it comes to applying these procedures on these patients, they're going to practice aseptic technique, but when we're dealing with these patients, we ourselves should also practice aseptic technique. The first one we're going to talk about is what's called a tracheostomy. Let's break this word down. This is to do with the trachea. Have you ever seen a patient where they have that little slit in their trachea on their throat on the anterior surface so they can breathe? That is a tracheostomy. You will see some of these patients, and it doesn't say here on the PowerPoint, but this is something that you definitely want to cover up for, put gloves on, make sure you have a mask on, even though we should all have masks on anyway currently. And I'm going to tell you why. If you have not encountered one of these patients with a tracheostomy, they can be quite gross. A lot of fluid comes out of those things, especially when they cough. You'll hear them trying to talk and all kinds of gunk is coming out of those tracheostomies. There's all kinds of stuff in the air flying out of that tube. You want to definitely protect yourself and your equipment around these type of patients. As far as the definition, this is going to be an operation performed under sterile technique that involves incising the skin over the trachea. They're going to make an actual surgical wound. They're going to make an actual slit or hole in the trachea, and they're going to put that little device, which I'm going to show you what it looks like in a second, that little device in the slit. They're going to secure it so the patient can properly breathe. Now, why would this be done? If there's any kind of obstruction of that airway, if the trachea is obstructed in any way, the patient is suffocating, cannot breathe, it's an emergency procedure that's done. It's not something that's going to be done randomly out of the blue. This is primarily an emergency procedure done as a last resort to free up that airway so the patient can breathe. And they're going to keep that device in there for a while until they can make sure that trachea is properly functioning before they remove it. Has anyone dealt with a tracheostomy patient yet? I know you've only been there a week, but you will see these quite often. And that's what it's going to typically look like right there. That's the device that will actually go into the trachea. And this is why I'm saying you want to make sure you have a mask on, gloves, gown, because when people get to coughing or talking, and these people will try to talk to you, guess what's coming out of this little hole? All kinds of nasty fluid and droplets. It can be quite disgusting. So you definitely want to protect yourself. Make sure you're practicing that proper aseptic technique around those patients, because some of those fluids could accidentally get on you. It's not the patient's fault, but make sure you're protecting yourself accordingly. And don't let it freak you out. It can be kind of intimidating if you've never seen that before. Especially if they get to coughing and all that nasty stuff's coming out. It is quite normal for those fluids to come out of there. And that's just showing you a diagram of what that looks like. They're going to create that little slit right here on the anterior surface of the neck. Right here. They're going to actually stick that tube into the trachea. It's going to allow that patient to breathe if there was an obstruction down here keeping them from breathing. Keyword is this incision, this area, this opening is what we call a stoma. You want to make sure you remember that word. It's called a stoma.
You said the incision itself is called a stoma?
Yes. You'll also hear that referred to whenever we talk about intestinal procedures. Some people have parts of their intestine exposed. You'll hear it referred to as a stoma sometimes as well. That'll come later. Same terminology.
Are they going to always be hooked up to some kind of oxygen source as well too, or is that?
Not necessarily. Not necessarily. Like you see this guy right here, there's no oxygen anywhere on this patient. You know, it's just a cartoon of a guy, but sometimes they'll just simply be this one device right here and simply just providing an airway so they can breathe because they have an obstruction going on that trachea. More extreme cases though, they may actually be hooked up to equipment, yes.
Okay, but you can still just rely on like room air to be fine with that?
Yes.
Okay.
Yes, definitely.
And do they, is that the one, are they able to talk with the hole open like that, or do you have to cover it up?
So in a limited fashion, and that's why I'm saying sometimes if they try to talk to you, they'll forget to put their finger over that hole. Sometimes they'll put the finger over their hole so they can talk. Because if you try to talk with that opening, the vocal cords aren't going to work properly. It's going to come out nasty. They're going to cough. All that gunk's going to come out of that hole. So you'll see them often put their finger over their neck right here so they can talk. And have you ever seen people that have that permanently? People that are heavy smokers sometimes, and they lose the ability to talk. They have that little stoma there. They'll put their finger over the hole so they can talk. I'm sure you guys have seen that before. Same concept. Same concept. Okay, so now we're going to go to thoracostomy tube. So I don't want you to mix these two terminologies up. Let me go back a second. We talked about a tracheostomy that's dealing with the trachea. This next word is very similar. This is what we call a thoracostomy. Keyword thora, which is referring to thorax. So this is a very fancy way to say a chest tube. A chest tube. Thoracostomy tube. So why do we have these done? We have these done primarily to drain that intrapleural space in the mediastinum whenever there's fluid or air present. How does it do this? It does this by what we call negative pressure. Negative pressure. You will do with a lot of these patients with these chest tubes, especially after surgeries. A lot of people after surgeries, typically if it's an emergency surgery, have that fluid or air build up in those cavities. And those chest tubes are often surgically put in to relieve that air and fluid to keep them from getting a really bad infection and drowning on their own fluids. Happens quite a bit during surgeries. You will go into rooms on portables with these. This is where I was talking about a lot last semester and a little this semester, where you gotta be super careful around these patients, because these are the patients that have that device on the floor hooked up to that tube while those fluids and that air is being drained out of the chest. And the last thing you want to do is ever hit this accidentally with your portal machine, because you can actually dislodge that tube from the chest. You actually rip it out. cause a lot of pain, a lot of issues, because these tubes are actually sutured into the patient's chests. So why do we do this? What primary conditions would we have chest tubes? That'd be atelectasis, pneumothorax, hemothorax, pleural effusion, and empyema. We're going to define each of these in just a second here. We'll go through each of these specifically. So keyword is that negative pressure is how this device works. You'll never see one of those boxes for a chest tube at the level of the patient or above the patient. It will always be primarily on the floor. And that's something you should look out for as a technologist. If you ever walk into a room, because sometimes patients will play with their equipment, they're kind of ignorant to this stuff. They don't know how it works. If you were ever to walk into a room and you saw that chest tube box on the patient's bed or above their bed hanging, you would immediately want to make sure that you take that box and put it back on the floor. Because what's going to happen is, because this works on negative pressure, the only way that those chest tubes will properly drain is if that box is on the floor to create that negative pressure to pull or vacuum the fluids or air out. If that box is at the level of the patient or above, guess what's going to happen? It's going to reverse that pressure. Those fluids and that air is going to go back into the patient, and they could cause, as you can imagine, a major issue and or even kill somebody. So if you ever walk in there and see that, you immediately want to make sure those boxes are on the floor, let a nurse know, let somebody know, do your part to watch out for that. And of course, be super careful when you bring machines in there. Has anyone got to play with a Pearl machine yet? No? Well, you will. And those Pearl machines, they can get away from you sometimes, especially the newer ones. And you don't want to hit those boxes accidentally with your machine. It can cause major problems. Let's define some of these terms real quick here, guys. These are the primary sicknesses, primary conditions, primary pathologies that we would put a thoracostomy tube into a patient's chest for. The first one's going to be that atelectasis, and that's simply referring to a complete or a partial collapse of the entire lung or a lobe of the lung. So it's a complete or partial collapse of that entire lung or a specific lobe of the lung. And putting that chest tube in is going to hopefully, if everything's going properly, drain that excess fluid out so that that lung can reinflate and not be collapsed anymore. Pneumothorax, we talked about this last semester. That's simply that air that leads to that space between your lung and chest wall. This can also cause a lung collapse. But this is air primarily between the lung and the chest wall. So that chest tube is going to be put in there to drain that air out, to keep that lung from collapsing from the pressure inside that person's chest. So look at your keywords here. Once again, pneumo, you see the word pneumo, that always means air, thorax, air in chest. That's how you can break that down. Go to the next word, we can break this word down as well. You see hemothorax. Hemothorax simply refers to blood in the lungs. You see the word hemo. Hemo always refers to blood. Thorax, once again, is talking about chest or lungs. So blood, lungs, blood in lungs is simply what that refers to. And obviously, it goes without saying we don't want any blood to be present in our lungs. That would need to be drained out as fast as possible. Pleural effusion, we talked about that one last semester as well. Pleural effusion is simply fluid in the lungs. And I don't think I need to explain why we should not have fluid in our lungs. You end up drowning on your own fluids within your lungs if you leave that in there. It can cause extreme infection, extreme coughing, can suffocate a person to death. We're going to put that chest tube in there, drain that fluid out using that negative pressure, relieve that person's chest so they can breathe more properly on their own. And the last one there is going to be empyema. Empyema simply refers to pus found within the lungs. Pus is another thing, much like blood and air and fluid. Blood and fluid. We do want air in the lungs. Blood and fluid in the lungs. Pus is the same concept that can cause a person to drown or suffocate on their own fluids. We definitely do not want that, so we got to drain that properly out of those lungs. Pus will be present a lot for people with pneumonia. It tends to cause a lot of pus in the lungs. When I had pneumonia, I've had pneumonia twice. When I had it twice, same concept. I had a lot of pus in my lungs. They had to get that out very quickly, or I could have suffocated on that. If you ever had pneumonia, you probably know what I'm talking about. If you ever had severe pneumonia before. But those are the 5 primary pathologies that we will have chest tubes for. Obviously, there are other instances where we can use chest tubes, so it's not the only reasons. I would throw in there, like I said before, a lot of surgeries, especially emergency surgeries when things may not go as they should. a lot of times patients' lungs or the chest cavity will fill with air or fluids, and they'll often put those chest tubes in very quickly for patients to relieve that lung or chest space. My wife, for example, she had emergency surgery on her heart, and they had to cut her chest open and do emergency CPR. And after they brought her back and saved her, she had to have 4 chest tubes in her chest because so much air and fluid had built up in the lungs as a result of that emergency surgery. And she had to have those 4 devices going at the same time to get all that fluid out of the chest. And that's another point. That's not necessarily just one chest tube. There can be multiple chest tubes. My wife, for example, had 4 at the same time. And she can tell you, she's told me multiple times, it's one of the worst feelings, by the way, having those chest tubes in your chest. She said, just no way you ever are comfortable with that in your chest. And you can imagine having tubes stuck inside your chest, directly in your lungs. I can't imagine that being comfortable. But she always told me that the worst feeling of all is when they would remove those, because it felt like they were ripping your lungs out because they're sutured in. They undo the sutures, they pull that tube out. She said it always feels like they're ripping your actual lung out of your chest. It's one of the worst feelings on the face of the earth. Anyone ever had a chest tube before? I haven't. I don't want to. I don't want to. After the story she's told me, it sounds terrible. But be careful. I keep saying it a lot. Be very careful around these types of patients because you will encounter them a lot in the ICUs. And you gotta make sure you're watching your equipment, watch where you're going. And that's a little bit what it would look like if we looked inside the body. That's that chest tube going directly into the lungs through the chest wall. It would actually be sutured in like we see right here. They're actually gonna stitch that in. And as you can see in that picture, very uncomfortable, not the most pleasant thing. And another reason why you want to be careful with that equipment, if you were to hit that device accidentally, it would actually rip this thing out of the person's chest, cause further injury. You're going to make everyone really mad. They're going to be cursing you out. Be super careful. Be super careful. I have personally not done that before, but I've seen other techs do it, where they knock these tubes out of people's chests because they were being careless. Okay, where are the most common insertion sites? Because we do have what we call common insertion sites. The most common insertion sites are going to vary depending on what area of the lung the fluid is present in, or what area of the chest cavity the air is present in, depending on what pathology is present. But the most common area that we're going to insert these chest tubes is going to be what we call the 5th to 6th intercostal space. When you see the word intercostal space, that's simply referring to that space between each rib. So you see the rib cage, those spaces between each rib is the intercostal space. We're going to insert that tube typically between the 5th and 6th intercostal space specifically, because that's the most common area where fluids tend to build up within the lungs. We're also going to insert at what we call the lateral and mid-axillary line. And there is a range. We're never going to go higher than the 4th intercostal space, and we're never going to go lower than the 8th intercostal space. So 4th to 8th is the range where those chest tubes will be inserted into the body. 4th to 8th. You won't go higher than the 4th. You won't go lower than the 8th. And one more time, those intercostal space are those spaces between each rib. They actually each have a number, much like the ribs are numbered. Each intercostal space itself is numbered as well. And this is what the device will look like, guys. When I talk about that box that's on the floor where the chest tube is connected to, they look just like this. Some will have different variants depending on the brand. This right here on the right, this plastic tube, this is the actual chest tube. This is the actual chest tube right here, coiled. This is the part that goes inside the patient's chest right here. And you will see all these little numbers on this machine, and you'll see when you walk into a patient's room, there's going to be liquid inside here. It's going to be a brown, yellowish liquid. That is the fluid and the air. Well, not the air, but that's the fluid that's being drawn out of that patient's chest via that negative pressure. And it's going to fill all the way up here, depending on how severe it is. Another thing you want to watch for when you go in these rooms, guys, if you ever walk into a patient's room and you see that fluid all the way up here, please tell somebody, tell a nurse. Not every nurse is doing their job very well or properly, and they may overlook this. If that's about to overflow, they need a new box with not a new chest tube, but a new box hooked up immediately. Because as you can imagine, with that negative pressure, if it's overflowing, it's going to risk retrograding back into the patient's chest. So it needs to be changed out. So do keep an eye out for that. Make sure you watch out for it, not only as far as moving your equipment in there, but make sure it's not overflowing. You don't send that fluid back into the patient's chest. This right here is a little clamp. Sometimes they will give the patient relief. If they don't need to have any more drainage, they'll clamp that off. They'll keep that drainage from happening. And we do perform a lot of chest x-rays for these types of patients because we actually check the placement of those chest tubes. Sometimes if a patient's in a bed, they're rolling around. If they roll around in their sleep like I do, I roll around all over the place while I'm sleeping, they might dislodge that tube. It might come out of place. So we're going to do those daily morning chest x-rays every morning on a chest tube patient. And that is something you want to remember. We always do a daily morning chest x-ray for every chest tube patient because there are chances that tube may become dislodged or moved. And if it's dislodged or out of place, obviously it's not doing what it needs to do. That patient's lungs is filling up with more fluid, and we need to get that back in place immediately. I've already said this enough. I don't have to repeat it again. Don't catch your x-ray machine on that tubing. An exterior assembly of the chest tubes must always remain lower than the patient's chest. That's primarily, once again, due to the negative pressure. If we do not have that assembly below the patient's chest, that negative pressure will not take place. It's actually going to reverse and go back into the patient's chest. And then, of course, be careful if you're ever moving these patients. Even though these tubes are sutured into the chest, they aren't quite easy to dislodge, even if you're simply pulling a patient up to simply put a cassette behind them for a mobile chest x-ray. So be extra, extra careful. Extra careful. Gloves, mask, gown, aseptic technique, like everything else we've been talking about, because that is considered an open wound directly in that patient's chest. So you gotta be extra careful around that. And that goes for really, I mean, any kind of patient you walk in on, guys, especially in ICUs, you're gonna see people hooked up to so much equipment sometimes. I mean, there is dozens of lines and equipment all over some of these people. And I know I've repeated it a lot, but you've gotta really be aware of your surroundings because it is so easy to accidentally hit this stuff, especially with a big bulky x-ray machine. You kind of get into your routine. You're not thinking, you're not paying attention to anything. You might pull a line out. You might pull a lead off of someone's chest. Alarms start going off and you're like, oh my God, what'd I do? So always be aware of your surroundings whenever you go to these patients' rooms, because some patients, they're gonna have multiple chest tubes. They're gonna have a million other lines hooked up to them. And never be afraid to ask for help. If you walk into one of these rooms, don't ever just try to do it by yourself. I've worked with a lot of techs who just don't like to ask for help. I mean, I used to be that way myself. I used to think I could do it all by myself, but you need to ask for help, especially the nurses. Let them assist you moving those patients, because if you haven't encountered this yet, you will. For some reason, nurses see x-ray techs. They all go running away from you like you got the plague. They seriously all go running away from you because they think they're gonna get zapped by x-rays. It's like you're gonna start getting a complex, like, oh my God, I have the plague, everyone runs away from me. That's probably an x-ray tech. They see the machine, they run the opposite direction. Call them right back in and say, hey, if you want this x-ray, you need to help me move this patient, because I'm not gonna risk my job knocking a chest tube out or knocking lines off of somebody just because you're scared of my x-ray machine. So you do gotta get used to asking for help constantly, because I'm telling you, these people will run away from you so fast, they literally disappear. Stick your head out that door, call down the hallway, say, hey, if y'all want this chest x-ray, you better send me some help right now, because I'm not lifting this patient by myself. Don't ever be afraid to do that, because I promise you that's gonna happen to you. And this is what a chest x-ray would look like with a person with a chest tube. I don't think I need to point it out to you guys. It's pretty obvious, but there is the chest tube right there, coiled inside the lungs. And this is what we want it to typically look like. If you did a chest x-ray and this line was not coiled, like it ended right here, for example, that would tell us that that patient's chest tube's been dislodged. They would need to replace that tube as quick as possible, and they'll call you right back for another chest x-ray, because we are the eyes for this exam. Anytime a chest x-ray is put into a patient, they're gonna immediately call for a chest x-ray to check that placement. Along with those morning x-rays I talked about before, You're going to do a daily x-ray every single morning to make sure that tube is still in place, because they are very easy to dislodge from a patient's chest. If you look here in the x-ray as well, when I was talking about those intercostal spaces, that's that space right here between the ribs. That's the intercostal space that we're talking about. And each one of these is numbered. So first intercostal space is right here, by the way. 1, 2, 3, 4. You're never going to see a tube above this. 5, 6, 7, 8. You'll never see a tube below this one right here. So it ranges at 4th to 8th intercostal space. If you walk in and see an x-ray and that tube's down here, we got a big problem. That tube's not in the right spot. Or if it's way up here, we got another problem. It needs to be in this range right here. 4th to 8th intercostal space. And by the way, can you guys notice how this lung is whited out? See how this is a nice healthy lung here? This is all fluid in this patient's lung. It's 100% filled with fluid. That's why they have that chest tube in there to drain all that out. Okay, so we're going to talk about urinary catheters next. We're going to talk specifically about the indwelling catheters. So we as technologists not only walk in on patients that have these catheters in place, but there are certain exams that we do as radiologic technologists where we have to actually insert catheters into patients. Now, I'll tell you right now, me personally, not a lot makes me squeamish, but inserting catheters is my weakness. Seriously, I can do any other exam, but for some reason inserting catheters makes me squeamish, gives me chill bumps, makes me sick. That's just me personally. But that is something we do have to do as technologists, especially for what we call cystograms. Cystograms are studies of the bladder. We talked a little bit about that last semester, but on those exams, we as techs have to actually go in there and insert the catheters properly. Obviously, this needs to be an aseptic technique when inserting these catheters. Why? I want you to remember this. Catheterization causes the most infections out of any other kind of procedure in the hospital. Catheterization specifically causes more infections than any other procedure found in the hospital. And that's due to people being careless, not properly using aseptic technique, whether they're inserting the catheter or treating patients with the catheter. And the area, the urethra, is very susceptible to infections, as well as the bladder. Just a very easy area for those infections to enter into the patient. So we have two main types of catheters we are going to talk about. And I see a couple of you with your eyes closed. If I can get you to look up, please. Jalisha, thank you. So two main types of catheters, guys. We have what's called the Foley catheter, also known as a retention balloon. And we also have what's called a straight type catheter. Straight type catheter does not contain a balloon. A straight type catheter will be placed into a patient, usually held in place by somebody during a procedure or taped to the patient. Not the most effective, as you can imagine. The most common type of catheter you will see utilized are going to be those retention balloon Foleys, because that catheter is inserted into the patient's urethra. They inflate the balloon to keep it into place. That way, no matter what's going on with the procedure, as well as when they're staying in a hospital room, people roll around, move around, it's not going to become dislodged, and they can properly urinate as they need to. And I do have a very interesting story to tell you guys about that next, about Foley catheters. So what are the main purposes of Foley catheters? That's what we're going to focus on, because honestly, in my career, I've never seen straight catheters used. That's a more old school method. The Foley catheters are the most common ones we're going to use with the retention balloons. Why do we use them? Specifically for bladder emptying, relieving that bladder retention to irrigate the bladder if that urine's staying in the bladder for too long. Also, we're introducing drugs into the bladder. By the way, contrast mediums fall into that category because we introduce contrast during procedures. They're going to permit the accurate measurement of urine output, and they're going to relieve incontinence if the patient is suffering from that. Now, are y'all ready for a very painful story? My male students especially, because this is gonna really hurt even me just telling this story. So let me tell you a story about a Foley catheter that I experienced as a student. This is my very first semester, by the way, as an X-ray student. I think it was my 4th week in clinic, as a matter of fact. We had a patient come in who was in the EC, and he was having issues urinating. So they had to put a Foley catheter into him to help him urinate. Well, this guy decided he had enough of staying at the hospital. He was sick of being in there. He wanted to go home. He had had enough of the staff, the nurses, the X-ray techs, and everyone around him. Now, he did have a Foley catheter placed into his urethra with a balloon inflated, by the way. So he decided he was going to remove that Foley catheter all by himself and get out of this hospital because he had enough. Well, as you can imagine, that balloon does what? Keeps that catheter lodged inside of you so that very thing cannot happen. So he started pulling. It wouldn't come loose. He started pulling some more. It would not come loose. He gave it one final tug and ripped the Foley catheter out of his urethra. But guess what else he did? He ripped everything else out of his urethra. I'm talking about he ripped his urethra out and all the meat in between. He ripped everything out of his penis, to be completely straightforward here. He ripped everything out. So everyone walks in, and here he is with the catheter out. Everything else is pulled out internally, and there's blood everywhere. Like, it looked like something out of a horror movie. So long story short, this guy, they attempted to put everything back in, but he was permanently damaged. They could not reverse that damage, as you can imagine. We ended up doing multiple cystograms on him to try to find a way to repair this, but they never could repair this person's issue. So if you ever find yourself with a Foley catheter, please, for the love of God, don't try to take it out yourself. That balloon's there for a reason. And by the way, don't ever walk up to a patient and pull on that. Don't ever snag your machine on that. Don't ever snag your machine on that, because that can happen. Or they're going to end up like this poor fella who will never urinate the same again. So that's my Foley catheter story. That was my introduction to cystograms, by the way, when I was in clinic. Very horrible thing. It still makes me hurt just describing it. Very horrific stuff. But yes, be careful around Foley catheters, and don't ever pull one out yourself. So as far as putting them in, guys, there is a specific procedure for inserting these catheters. The very tip of that catheter must be introduced into the urinary bladder cavity. If it is not properly placed, it will not work as it needs to. This does work on a very similar function as those chest tubes do, wherein that catheter bag must always be hanging below the patient. If you ever see a bag, like same concept, guys, you ever walk into a room and that bag is like on the patient's bed or above them, you want to make sure that bag is below the patient. Otherwise, that urine is going to be going back into the bladder. And as you should know, we don't want that to happen. They're trying to have the bladder leave the body. Catheter tubing will always be taped to the inside of the leg. By the way, that is a safety measure to keep things from happening like I just described you. If someone was to snag that accidentally, that tape is a little bit of a fail-safe to keep that catheter from being ripped out. The very end of the tube will be attached to that drainage bag. Once again, it must be lower than the patient because there is a retrograde process to pulling this bladder out. The retrograde process cannot occur if that bag is not below the patient's bladder. It works on a gravity-based system to draw that urine out of the bladder and help keep that bladder empty. And by the way, I will say this very plainly because this is a common problem that people face, because you will assist with these guys putting catheters in quite often, especially if you're ever going to pediatrics, because bladder issues are a major issue that children face constantly. But guys and girls, I say this for guys and girls, for female patients, guys, make sure you are putting that catheter in the right spot, because it is very easy to put that catheter in the wrong spot. And a lot of techs have done that. You can cause the patient a lot of pain and discomfort, especially if you think you have that catheter in the right spot and you start introducing contrast into the wrong spot. Be very careful, The urethra and the vagina are two separate openings. To put it plainly, guys, make sure you are aware of that, especially if you're assisting with putting these catheters in. There's a proper way to do it. Make sure you're putting it in the right spot. And for males as well, guys, there's a certain process for that. You always want to make sure that it's properly lubricated. If you're ever assisting to put a catheter in, if you have not lubricated that catheter, guys, you're going to cause the patient, whether they're male or female, in a lot of extreme pain, because patients are conscious 99% of the time when catheters are introduced, even though some of them may be sedated. Make sure you always put lubricant on those catheters properly. And when that balloon's inflated, do not touch it anymore. So if you want a more accurate representation of what happened to that guy I was talking about, guys, see where that balloon's inflated? When he pulled that catheter out, this balloon stayed inflated and pulled all this out. That's what I was referring to. Yeah, very horrific. And this is just an x-ray, guys, of what a typical cystogram will look like. Without me pointing to it, can you see the catheter tip on that x-ray? If you cannot, it is right here. There's the catheter tip. And we do, once again, want to make sure that catheter tip, the tip does need to be in that bladder. If we're doing a fluoroscopy exam or an x-ray and we see that tip down here, that's a big issue because that catheter tip has not been inserted correctly. We need to fix that very quickly. Okay, intravenous and intra-arterial lines. Two more types of lines that we will deal with on certain patients. These are still, just like everything else we've talked about, introduced via sterile technique or aseptic technique. And these will be directly inserted into the veins or the arteries of a patient, depending on what's needed. And these are primarily for introducing meds to patients who might be having like heart issues or blood flow issues. They're going to insert those medications through those lines directly. You'll sometimes see them down here in the patient's arm. Sometimes you'll see them inserted higher up by the collarbone. It depends on what kind of condition they have and what's going on. But those lines will be traced all the way from the veins or arteries all the way directly into the heart, as you can see in this diagram right here. Okay, and they can be classified into two groups. They can be classified as either venous or arterial. Once again, it depends on what condition the patient has, what kind of issues they're having specifically when it comes to their heart issues, but those will be either venous or arterial. And just like with the chest tubes, guys, they do require imaging, specifically every morning. You're going to do morning x-rays on these arterial lines to make sure that patient has not accidentally dislodged it out of place. Because much like the chest tubes, as people move around, it can become quite easy to move these around, dislodge them, let them fall out of place. We got to do those chest x-rays constantly to confirm that placement, as well as when they first put it in, you'll get called in for these for line placement chest x-rays to make sure they actually insert it into the correct area. I've done so many of these on children because with children, it's very hard to get those lines in properly because a child is much smaller than an adult. And feeding that line into those veins and arteries all the way through the heart is quite challenging. I would end up doing 4 chest x-rays sometimes in a row just to see if they can get that line into place properly because it can be quite challenging. But we do work alongside those nurses and doctors constantly to make sure those lines are properly placed. And once again, guys, I say this a lot for a reason. Be ever aware of those lines. It's easy to snag your equipment on it. It's easy to step on it. It's easy to get your arm stuck on it, whatever. Always be aware of your surroundings. Be careful where you're walking because those lines can be ripped out of patients quite easily. Okay, pacemakers, something else that we will deal with a lot in the hospital. What is a pacemaker? That is a permanent electromechanical device inserted directly under the patient's skin. It's going to help regulate that heart rate for the various patients with their heart conditions. A pacemaker is literally inserted in a flap of the skin anterior to the lungs, right above your heart. And it's not down in the heart. A lot of people think the pacemaker is like in the heart. It's actually just in a flap of skin. But then the lines will actually connect and be traced all the way to the heart, arteries, and veins. It's going to keep that heart regulated, keep it on beat, keep it beating properly. They are approximately 1 inch in width and diameter and thickness, typically about 1 ounce. That's very, very small, very tiny. And your role as an X-ray tech, you're going to operate the fluoro unit if you're ever in on one of these procedures, because as you can imagine, that can be a very intricate process, not only inserting that pacemaker in the right spot, but making sure the lines of the pacemaker are actually connected to the correct arteries and or veins, because that pacemaker is actually sending electrical signals to the heart. If it's in the wrong spot, they can end up killing the patient. So you're the eyes of that doctor for those procedures. We're going to actually place guide wires. Guide wires are literally that. They're actual wires that go through the device into the veins. They'll put the guide wire into the vein. The guide wire is radiolucent, so we can see it on the X-ray device, and they can make sure and confirm that guide wire is in the right vein, so they can trace the pacemaker lines into those proper veins and arteries. Some pacemakers are dual purpose. Some may be simply a pacemaker. Some may be a combination of pacemaker defibrillator. Pacemaker does just that. It keeps the heart on pace, keeps it beating properly. Defibrillator is just that. Just like a defibrillator would use to bring someone back during CPR, a defibrillator will actually be implanted on that device as well. Should the patient's heart go severely out of rhythm, it'll actually shock the patient's heart back on rhythm. My wife has one of these. She has a combination pacemaker defibrillator in her chest. My wife has a heart condition called long QT syndrome. If you've never heard of that, her QT intervals of her heartbeats are prolonged and they don't beat properly. So she has that pacemaker to keep it on pace, but every once in a while that condition will accelerate and she'll actually get shocked with that defibrillator portion of that pacemaker. Like in fact, it'll wake me up at night sometimes, like it'll shock her in the middle of the night. You can actually feel the shock. Kind of scary until you get used to it, but she does have one of those combination pacemaker defibrillator devices I was talking about. And that's the location they will always be located on adults, guys. You will always have that pacemaker on the left side of the patient, directly on the over the pectoral muscle. This is what they look like right here. This is what my wife's looks like, as a matter of fact. She has the same looking device, except hers is a pacemaker defibrillator combination. Those are the lines that go into the arteries and the veins to deliver those electrical shocks properly. And this one's going into that subclavian vein right here. But sometimes they do go into the arteries depending on that patient's condition. So quick question here, guys. So on adults, as far as pacemaker placement goes, it is always going to be located on that left pectoral muscle, over it, as a matter of fact. But let me ask you this, for babies, because some babies have to have pacemakers, do we put the pacemaker in the same spot, or is it put in a different spot? Does anybody know?
Wouldn't it be different because they're smaller? They're children, they're smaller chest.
It will be in a different spot, yes, but the device will not be smaller, by the way. The device is the same size whether it's an adult or a baby. But for babies specifically, you'll notice if they have a pacemaker, they actually put it in the baby's abdomen, not above the chest. Now, as they grow older, they may move that to the chest, to the normal area. But all babies will have that device put in the abdomen because a baby's chest is so much smaller, it would actually cause damage putting that device there. So they'll put it in the baby's abdomen because there's a little more space to work with. So if you ever see a patient, a child, baby that has a pacemaker in their belly, it's not because they swallowed it, it's because that's the area they have to put it until the patient becomes an adult. Because of the space and area where that needs to go. They don't want to cause extra damage to that patient, that baby or that small child. And my wife's device actually, because I've seen her x-rays, similar path, her leads go right here into the right ventricle, but they also go into the left ventricle and both atria. She's got multiple leads going throughout hers to keep her heart on track. I'll tell y'all her story one day when we get to it. in another lesson how they almost killed her, actually, changing those leads out, because the leads do deteriorate. Pacemaker leads deteriorate over time, just like anything else electronic. They have to switch them out every few years. It actually almost killed her doing that one time. I'll tell you that story another date, though. Quite the crazy story. And that's what it's going to look like on a nice chest x-ray, guys. So once again, you see a patient on a chest x-ray with this electronic device right here. That's totally normal. That is the pacemaker device or the pacemaker defibrillator. This one has two lines, as you can see. There's one in the atrium of the heart and one in the ventricle of the heart down here. But you will see those leads in various areas of the heart. It depends on what kind of condition they have and how those different chambers are beating on that patient. Because different people with different conditions, the atria or ventricles don't contract properly. Pacemaker is going to deliver those little electrical impulses to make sure it's beating in the proper fashion. Like I said, my wife has 4 because none of her chambers beat properly at all. Okay, neonatal portable radiography, something I have done a ton of, but something that you will actually experience at Harris Health as well, because there are neonatal units within Harris Health. So neonates are very, very high risk, extremely high risk, especially premature babies. Premature babies do not have fully developed immune systems. So we have to exercise extreme precautions, sterile aseptic technique around all neonates, because they are very susceptible to infectious agents, airborne, touch, all the above. You always want to gown up, you always want a mask on, you always want sterile gloves, because just the smallest bit of bacteria, the smallest infectious agent can infect these babies and cause them to completely crash. Sepsis and nosocomial infections are one of the major threats they're going to face. And there are various strategies to obtaining x-rays on these patients. This is an instance, especially like this picture we see right here. A lot of these babies are going to be in incubators. You never, ever want to be in a situation where you're doing this by yourself. You always want to call a nurse over to assist you, because the last thing you want to do is touch that baby. And when I tell you this, guys, I tell you this from experience, these babies, sometimes they're so sensitive, the smallest touch can set them off and make them code. Babies are ultra sensitive to the senses, sound, and infectious agents. And I say sound for a reason too, guys. If you ever go to a neonatal unit, it's typically very quiet, because premature babies especially can crash from loud noises. So let's say you're going through a neonatal department, you crash into a wall, you cause a lot of noise. You can actually cause those babies to code from loud noise. So never go in there hollering, shouting. You know, we like to say x-ray really loud. You want to avoid saying x-ray really loud, like you typically would, because those noises can cause those babies to crash. Cross-infection is a major issue in neonatal units. You know, one embarrassing story I can tell you about neonatal. You didn't hear this from me, by the way. Texas Children's would probably kill me for saying this. They once had a bed bug infection breakout in the neonatal unit, Texas Children's. Someone walked in that wasn't screened properly. They brought bed bugs from home, and it infested the entire neonatal floor, the 4th floor on West Tower. They had to shut the whole thing down. They had to move all the babies out, cause a huge, huge deal. And it's because those babies are so susceptible to infectious agents that they can just crash and die on you in a split second. And some of these babies, guys, let me tell you, to give you some perspective. If you've never dealt with neonates, they can be so fragile and so small that I've seen some that can fit in my palm of my hand. They're so tiny. So you don't ever want to try to attempt to move these patients by yourself. There are strategies for getting the x-rays. Most of the neonatal patients will have little x-ray trays underneath their bed where you can stick your cassette under there so you don't have to touch anything. Let me put it this way. As much as I preach about quality, when it comes to neonates, sometimes you're just going to get the best x-ray you can get. So don't go in there and say, well, I'm going to move them around. I'm going to get their chest straight. Like this baby right here, you would not want to touch this baby, because you risk causing that baby to crash and infecting them with some kind of infectious agents. So be very careful, very, very careful. Ask for help, and be aware that these babies can literally code at any second, any time of the day. And you are expected to get every manner of x-rays on a patient like that. whether it be arm x-rays, leg x-rays, chest, abdomen, skull, you still are expected to get those x-rays as best as possible while properly manipulating that patient or having someone manipulate that patient for you. They're primarily going to be in ICU areas. And let me add this, they will be called NICU areas. In ICU, that's code for, that's the area where all the babies are, ICU babies. A lot of your premature babies, a lot of your very ill babies, they're all going to be in that NICU area. Come on.
Mr. Donahue, would the nurse be able to move them? I know there's different like levels, like, you know, a level 2, they're about to go home. Would you be able to move those kids? While a level 4, I know we wouldn't touch because they'll be like very, you know, ill.
So that's a good point to bring up, Isbete. For those of you who don't know, there are certain, like she said, there's levels of conditions with these NICU babies. We'll get more into that in RadPro 4, where we'll specifically talk about all that. But the ones that are about to go home, like she was just saying, guys, you would be able to manipulate them more, but you still, even in those cases, want to make sure a nurse is nearby to help you, because even then, some of these babies are so fragile. You've never done pediatric radiology. Babies are so, their bones are so fragile. You never want to just be in there roughly moving their limbs around or moving their chest around. They're in very serious conditions. You always want to ask for help. Don't ever try to do that by yourself. That's coming from experience, guys. Always ask for a nurse, or even if parents there. Parents can help you as well for the ones that are about to go home, not for the ICU ones. Okay, portable and surgical radiography, guys. I think it goes without saying, we've talked a little bit about surgery. We must have strict sterile technique when we're in surgery areas, whether we're using a C-arm or bringing our portable machine in there. Sometimes you have to bring a portable machine into a surgical suite because a doctor may have left an instrument in a patient. Sounds funny, but you would not believe how many times doctors leave instruments in patients or think they leave instruments in patients. What do you think the most common thing a doctor drops into a patient would be? Anybody? What do you think?
Scalpel?
Sponge?
Scalpel? Good guess. Not scalpel though.
A sponge?
Gauze.
Scissors?
Maybe a clamp.
Glasses.
All good guesses, all good guesses. But believe it or not, the most common thing dropped into patients are needles. Needles. If I had a nickel for every x-ray I've done looking for needles in patients, I'd be quite rich right now. They always think they drop needles accidentally. They're very easy to lose track of. But also you'll see when you're ever in a surgery case, some of you brought up the gauze, because gauze is left in patients a lot as well. They actually count the gauze. They keep an actual number record of the gauze because of that very reason that so many doctors have left instruments and gauze in patients. They actually number each piece of gauze and they keep track of it on a log. You'll see that if you're ever in surgery. It's kind of scary. It's kind of scary how often it happens, but people get stuff left in them all the time, all the time. Beware of that sterile corridor, guys. We talked about that last week. Portable fluoro, which is going to be the C-arm specifically, you're going to always need to make sure it's draped properly. If you're using a mobile x-ray, if you ever use a mobile x-ray with a cassette, you always want to make sure you have that covered as well. You never want anything to touch anything accidentally, and it's very easy. Probably one of the types of x-rays you'll do the most in surgery with a mobile x-ray would be spinal surgeries, because they constantly do x-rays of the spine while they're doing those procedures. And C-arm draping will have multiple designs. There are 3 major designs. There's going to be the one that's partially covered, one that's covered in 2 portions, and one that's totally covered. But surgical draping must be done for the C-arm. Don't ever get excited when you start using those C-arms and just rush in there and put that C-arm over the patient without a draping, because they're going to shut that whole procedure down. They're going to throw you out. They're going to curse you out. They're going to cause a whole uprising in that entire surgical suite. Make sure all of your equipment is properly covered before you use it in those surgical suites, so you don't get jumped in there. And once again, communicate, guys. Ask for help, because I'm telling you, I can't tell you how many times I ran into a surgery room, do spinal x-rays, and they see the x-ray tech. Everyone runs out of there like I got the plague, and I'm left in there with a patient cut wide open with their spine exposed, and they're wanting me to get an x-ray. I'm like, whoa, wait a second here. You guys got to come back here and help me set this up. I'm not about to break sterile field. I know you don't care, but I care. So can you guys come up here and help me set up my x-rays to make sure I'm not touching anything, make sure I'm doing it properly. Cover your tracks, cover yourself. It's gonna save yourself a lot of headache, especially if you were to accidentally break that sterile field. You wanna make sure someone's there with you, help you watch out for that.
How would you position like a patient, like if they're having an x-ray of the spine, if they're like, in my mind, I'm thinking that they're already like laying prone on the bed. So how would you position the patient?
Very good question, very good question. So they are prone on the table. What they will typically do is they will put an actual tray underneath that table, because there's a little connection point where you can put a tray under it and you can put your cassette in that tray. So the first thing you would do is your PA spine on a spinal x-ray. You'll go in there, they'll have the tray connected for you. If it's not, you want to make sure they know to connect the tray. You'll slip your cassette under the table, under those blue drapes, and you'll acquire that PA spine x-ray. Kind of hard to do, by the way, because there's so much in the way. There's so many drapes. You kind of have to shoot blinds. So I've talked to you guys a little bit about developing x-ray vision. This is where that x-ray vision comes into play. You almost got to see through the drapes and kind of almost guesstimate where the patient is. So it might take you multiple attempts. You might have to readjust that cassette to get that x-ray. That's how you get your PA spine. You go under the table with the cassette tray. How would you get a lateral? Because that would be the one you got to get as well. Well, they're going to set what they call a music stand. It literally looks like a music stand that you put lyrics on. It's a tray, a holder, much like the ones you guys have seen in lab, that sits on a stand. You'll put your cassette in the stand, set that tray on the side of the patient, and shoot crosswise across that table. Once again, you're kind of shooting blind again. That's how you would acquire that cross-table lateral on that spine x-ray. Very stressful x-rays to do. I've always hated doing them because I hate shooting blinds, but you literally are shooting almost with your eyes closed because you can't really see anything under those drapes, but you get used to it. You start getting that x-ray vision, you get used to where you need to put that cassette. But that's how you would typically do a spine x-ray in surgery. Yeah.
And will we be the ones like putting the cassette there, or we will ask the nurse to do it?
No, so that's a good point. So once you put that cover on that cassette, that's why you gotta get help, by the way. Don't be in there by yourself. You're gonna have a nurse that's already sterile hold that cassette and put it in place for you so that you don't actually touch anything yourself. It's okay if they touch stuff. That's where that communication comes into play. You gotta make sure that they're assisting you with that, because they're allowed to touch the cassette when it's covered. They'll put it in place for you. Then you can be very careful and stand over your patient, manipulate your tube, make sure you're not touching anything. But yeah, they would put it in place for you typically. Yeah, good question. Okay, so the most common types of C-arm draping that you will have used within surgery is what we call a snap cover. That is simply a C-arm covered with a sterile bag or cloth, and they use what's called a tension band to support it and keep it wrapped around that C-arm. It's literally just like that. It's a rubber band they put around that drape to keep it in place. So whenever you're moving that C-arm, the C-arm does rotate. Last thing you want is to be rotating that C-arm around a patient and it slips off. That tension band is going to keep that from slipping off completely. And let me show y'all what that looks like right here. I think I fixed the audio issue, by the way. Hang on a second here. I learned I was not hitting share computer sound for the videos. This should fix that problem. Does that sound better? By the way, guys, that's a specialized C-arm in that suite right there. This is some certain surgery suites actually have those C-arms attached to the ceiling. Like it's actually integrated into the room. So that's what you're seeing right there. That's not a mobile C-arm. It's actually in that surgery suite permanently. If you're ever asked to assist with this, guys, you will see that other guy does not have surgical get-up on. You are allowed to touch the undersides of that drape to assist putting it on your C-arms. That is considered okay. So that's why you see him without any kind of gloves or gown on. That would be like you guys, if you were a tech, assisting putting that on. As long as you're under that drape, not touching the outside, that is considered acceptable. So I like what they did there. That's my preferred way of draping C-arms as well, where they covered every section of that C-arm. A lot of people you will see when you get out there, they'll only cover that top and bottom portion where the receptor and the X-ray tube are located. But me personally, because you're going to deal with so many patients with fluids, like really a lot of fluids leaking out, you want to make sure every portion of that C-arm is typically covered, even though you're going to see a lot of techs not do that, and they'll be cursing when the exam is over and having to clean all the blood off their C-arm. So save yourself a headache. Find yourself the drapes, and your department should have them, by the way, the drapes that cover the entire portion of that C-arm. And not only are you going to protect the patient better, but you're going to save yourself a lot of work later, especially if those fluids get on your equipment. Okay, so that's where we're going to stop today, guys. I got 5 minutes left. We are almost done with this chapter. We will finish up on Wednesday, and then we will do a review for your test on Friday. Are there any questions about what we talked about today? All right, guys, well, enjoy PRE. I shall see you guys at 1 o'clock. We will get into upper extremity anatomy. I'll see you all soon. Bye-bye.